Good afternoon, everyone. My name is Daniela Rus. I'm the director of CSAIL and the Deputy Dean of Research for the Schwarzman College of Computing, and I'd like to welcome you to this edition of Hot Topics in Computing. Today, I am delighted to welcome Professor Daron Acemoglu. He is the Elizabeth and James Killian Professor of Economics at MIT, and in 2019, he was named Institute Professor. This is the highest honor at MIT. Now, Professor Acemoglu completed his PhD at the London School of Economics, and he was very young when he finished his thesis. He was only 25. I wonder if this is the youngest economist to have ever received a PhD. He lectured at the London School of Economics for a year before joining us at MIT. His research area is in political economy, and he made numerous contributions to this field, for which he was awarded the John Bates Clark Medal in 2005. This award is given to an American economist under the age of 40 who is judged to have made significant contributions to economic thought and knowledge. This is one of many awards Professor Acemoglu received. He also authored hundreds of papers and 2 books, of which I would like to highlight the very influential Why Nations Fail, which I read from cover to cover, and I highly recommend in case you have not read it already. And so with this, I would like to welcome Daron to tell us about optimal targeted lockdowns using a multi-risk SIR model, where SIR is an epidemiological model that computes the theoretical number of people infected with a contagious disease in a close population over time. Daron, take it away.
Thank you, Daniela. Thanks for inviting me, and thank you for that very kind introduction. It's a great pleasure to be here. So this is joint work with my colleagues Victor Chernozukov, Ivan Werning, and Mike Winston. And since time is short and I would love to get feedback, comments, criticisms, let me just jump into it right away. So I presume you can see what I'm sharing. So
yes, it's fine. It works.
You know, I don't need to tell you about COVID-19. Our whole way of life has been thrown upside down. And one of the things that's very interesting about this period is that we're actually trying to do the science and the policy at the same time, trying to find out both about the epidemiological, immunological aspects of the disease and how we deal with the social and economic aspects of it. So even though it's a tumultuous, sorry time for most of humanity, it's also a time for us to use our expertise and tools. And at some level, there has been it's been a success because there has been a lot of global cooperation. But on the whole, I would say we are still not successful even on the science part because we don't understand the pandemic very well. And certainly policy has not been very successful in most countries. In fact, we don't even understand the policy variation. So there's a lot to be done in terms of contributing to this field. And the reason why Ivan, Victor, Mike, and I jumped to this field, into this area, is because we think that it's also greatly in need of a multidisciplinary effort. So this is an epidemiological problem. Issues of herd immunity, mitigation, timing, immunity, all of these, you know, we have to take from epidemiological data and models. But there are economic and mathematical computational issues in terms of modeling costs of lockdown, different types of social behaviors. And as I'm going to argue, it's also an important computational problem that you have to approach these problems you know, modeling the various different dimensions of heterogeneity with various quantitative tools. So, and one of the things that we're going to be bringing to the table here is actually optimal policy analysis which does require some thinking and some extensions of existing approaches, as I'm going to explain. So one of the main starting points for us is that while several aspects of the disease are still being investigated, one property of it is very well documented. It's an extremely asymmetric disease across age groups. So if you look at mortality rate conditional on infection, it's more than 60-fold higher for the over 65 group than, say, the younger group between 20 and 50. If you go to even older age groups, such as 75, it becomes 2 orders of magnitude bigger. So this asymmetric mortality rate requires the existing approaches to be extended in order to look at the heterogeneous behavior and heterogeneous regulations of behavior, and that's where we come in. So we're going to develop a simple multi-group model. So multi-group models in epidemiology are not new, but what has not been done before is to actually explore optimal policy within this context. So if you look at, for example, the famous Imperial College Ferguson et al. Study, they have a very detailed structure, but then neither do they look at policies that differ by age, nor do they look at optimal policies. And as I'm going to explain later, this actually has fairly major implications for their conclusions. So we'll develop a multi-group SIR model, SIR standing for susceptible, infected, recovered, or SEIR, where you add the exposed group, which are asymptomatic for a while. We do it both, but I'll just talk about the SIR here. And the model is general and can be applied with multiple age groups as well as multiple other characteristics such as comorbidities. But for this talk, I'm going to focus on 3 age groups: young, middle-aged, and old. We're going to calibrate the parameters of this to COVID-19, and we're going to characterize and compute optimal control policy. And one of my main emphasis, as the main emphasis of the paper, will be to contrast targeting and no targeting. No targeting we call uniform policies, policies that apply to everybody. Now, even policies that apply to everybody, and I'll come back to this in the US context, for example, may be de facto differential across groups. But to start with, I'm going to really look at them uniform. They apply to every group in society versus targeting differential policies for different groups. And here is a high-level summary of both our results and our conceptual approach. So our conceptual approach is built on a very simple observation, of course, that we are implicitly or explicitly trading off deaths and output losses. Both of those are excessive deaths, excess deaths over what would have happened because of COVID-19, and excess output loss over what would have happened. We are not, as opposed to some other analysts or policymakers, we're not in the business of telling society where they should be, but our approach is to say, we want to characterize what's the menu of available policy. So that's the first conceptual step. So we're going to be characterizing what economists would call Pareto frontiers. So the thick line is the Pareto frontier when you restrict yourself to uniform policies. The origin, where you have 0 excess loss of output and 0 excess deaths, is where you would like to be. But of course, that's not feasible. So that convex shaped black line curve is showing you where you can be. For example, if your values or your policymakers' priorities are such, you can choose the maximally feasible control, which says, I'll take as much output loss as you want, but I'm going to minimize deaths. Or you can do some other combination. And essentially what I'm going to try to show you that when, instead of looking at optimal uniform policies, you look at optimal targeted policies, you go to this dashed line. So you can either save a lot of lives or you can save a lot of output, or a combination thereof. And quantitatively, these 2 curves are quite far apart. Those are the several main lessons from what I'm going to talk about. Okay, some caveats, and then I'll pose for some questions and then go through the details. First of all, as I said, we are four MIT economists, we're not epidemiologists, we're going to be using epidemiological data. But this is in the spirit of what I said. There is a lot that we can all do together as computer scientists, engineers, mathematicians, economists, epidemiologists, public health specialists, because I think this is a very multifaceted problem. And just looking at it from the viewpoint of one discipline is likely to lead to important omissions. Worse, I think, even though epidemiologists have done a great job, there's a huge amount of parameter and outcome uncertainty here. So in some sense, I think some of the early works like Ferguson et al., if they can be faulted, they can be faulted for the great degree of certainty that you can read between their lines. That was completely unwarranted. Even today, there is so much uncertainty about what's going to happen in 1 or 2 months' time. And in fact, optimums or policies in some ways can be very sensitive to parameters. I'll try to highlight that. But some other aspects are extremely robust. So in particular, the gap between targeted and non-targeted policies is extremely robust. And in what ways targeted policies improve over the untargeted uniform policies is extremely robust. So, but in that spirit of the understanding and recognizing the uncertainty and the multifaceted nature of the problem, we are very open to comments, suggestions, criticisms. And I think the more people are thinking about these issues, the better for our immediate or even longer term future.
Daron, this is such an important topic, and I just want to get a clarification. Does
Please.
Output loss mean economic loss?
Yes, and I'll be much more specific about what we do once I introduce the model, but yes, it's economic loss. Now, there are many other social losses, some of them having economic implications that we're not going to feature in our model. So people get bored, people have psychological problems because they're locked in, and all of those things we're not going to. So we're going to focus on some quantifiable, easily quantifiable economic aspects, and I'll be very specific about that when I go through the model. So I think this is a good point for me to pause for a second and see if there are any questions or comments before I go into specifics.
We don't have any questions on the chat yet. Please send your questions. And I just wonder, while we wait for a few seconds, how did you find the data that you needed in order to reach this important?
I'll be more specific about the data sources when we come to the calibration, but there are a lot of data out there. Some of them we don't have access to, some of them we have access to, but we did not choose our model to be as detailed as some of those data would warrant. But a lot of our data come from the Ferguson's report, which is very detailed, CDC, South Korea, and Italy.
And one more clarification. When you talk about targeting, how do you target?
So I think that's a great question. I'll come to that. I think first, let's look at what we mean by the policies in the context of the specific model, and then I'll talk about the implementation, which I think is definitely something that's not straightforward always, but there are ways, and we've thought about it. We discussed them in our work.
Awesome. Please go ahead, Daron.
All right. So here is the model in a graph. So if you just take the top chart here, the one that has ones as subscripts, that's a representation of a slightly extended one group SIR model. Everybody starts susceptible. They may get infected, so I'll explain how they get infected. In the context of some diseases, they get infected and that's it. But for for COVID-19, there's a crucial difference. You can have an acute case where many over 65 are having that, or a mild one. So we therefore allow two types of infections. We call them ICU or non-ICU. So ICU one has an ICU need. They may or may not get a bed, but they have an ICU need. And then the infected exit the infection state, and they can exit that in two ways. They can recover, or unfortunately, they pass away, they perish. So the mild cases don't end in death, so they all recover. but the ICU cases may end in death, and that might depend on other things like the care that they take. So what we are doing is that we're having multiple models, and we are allowing network contacts between these models. And the notation here is throughout standard: S for susceptible, I for infected, R for recovered, and D for dead, and NJ is the total population. So the standard SIR model assumes a quadratic matching technology. So it assumes that new infections is a function, or is proportional to the number of susceptible times the number of infected, because the infected interact with the susceptible and they bring the infections. Now, whether that should really be quadratic or some other functional form, we deal with that in the paper. There's some issues with the quadratic. It's not a bad approximation, but it doesn't really matter for any of our conclusions. And so here we follow the more standard epidemiology literature and stick with the quadratic. But if you care about non-quadratic, you should look at the paper. But the key thing here is that instead of the susceptible in group J being just infected by some monolithic group of infected populations, they are infected by those in group I, those on group K, IK, and the rate at which they are infected depends on the interactions between these two groups. So rho JK is the interaction between somebody from group J and somebody from group K, and then beta is the rate at which, conditional on interaction, conditional on contact, you get infected. And of course, to look at the total new infections in group J, you need to sum over all the groups with which an individual from group J can interact with. So, but we're going to make this a little bit more complicated because not every infected is going to be around, and we're going to introduce lockdown and slippages from the lockdown. So let me give a little bit more of the math. So we're going to have J groups, newly infected, they become a mild case with probability 1 minus iota J, or a severe ICU case with iota J. And the infections resolve at the rate gamma J, and that resolution is itself either in death, delta JT, or recovery, delta R JT. We're going to model this delta D JT, the death probability, as a function of the ICU capacity, because that's what the data from Italy and some of the data from other countries very strongly suggest. This doesn't really matter for any of the mathematical analysis, so I won't belabor that particular point, given that time is short, but I'll come to it in the calibration. Now, one important aspect is that even though in the US we have done a horrible job with testing and isolating, some of the policy tools and some of the social tools are about testing and isolating. Some of that will happen naturally because infected people will be in a severe state, they cannot go to work. So we model that in a very simple way. A fraction tau J of the non-ICU, because of contact tracing, isolation, testing, may not be in the infected pool, and a fraction phi J of the ICU also are severely infected, so they're not going to be lurking around and work or in shopping malls. So the eta J, which is therefore a composite of these iota J, phi J, tau J, is going to be the fraction of the infected who are not isolated, so they're going to be circulating around. And then one other parameter that, again, is important is once you recover, can you be identified as recovered, for example, by serological testing? And the fraction of those that are identified so they can actually go back without infecting other people is kappa J. Okay. Now, the key thing for our model is the lockdowns. So we're going to model lockdown with 3 key or 4 key parameters. One is a policy variable, 3 of them are parameters. First of all, the policy variable is LJ, which is the fraction of group J that are under lockdown. So they're not circulating around, they're not going to work, they're not going to shopping malls or to parks. Now, we cannot shut down the entire economy, so we recognize that by having an L bar J. So L bar J is those who are in non-essential work. If you lock down somebody, the cost of that in terms of economic output loss is WJ. So that's going to be the output loss of the group. That can be endogenized, but for now, I'll just take that as given, and we'll match that to data on wages in the calibration section. But very importantly, lockdowns are imperfect. So you can have a shelter-in-place order, but still deliveries will take place. Some people will not obey it. So you can close businesses, but some people go and visit their neighbors. So that's captured by this parameter theta j. So therefore, when you have a lockdown of LJT, T is important here because you'll see that optimal policy is strongly time dependent. So that's one of the problems of Ferguson's analysis, for instance. Then the fraction of interacting infections will be down from wherever it was to 1 minus theta j LJT. If theta j was 1, then everybody you lock down would be taken out of the infections. But if theta j is, say, for example, 0.75, for every 4 people you lock down, only 3 of them are effectively out, 1 of them still circulates. Okay. And then the key is vaccine and cure. So we assume that that arrives at some time t that can be stochastic. Let me take that in the calibration to be 1.5 years, just to show you some of the patterns in the clearest way. But whether it's stochastic or not doesn't matter for the results greatly, but its timing does matter a lot, as I will try to highlight. And of course, once the vaccine comes, it's not immediately rolled out, so those issues I'm not going to get into. All right, so math. So I have essentially summarized most of the model. So put in a math form, this is where we were, but now new infections are not just Sj times interactions, but has 2 more components. One is 1 minus theta j Lj. So that's taking people out of the susceptible group. The susceptible guys are not lurking around. And second, inside the summation, you have eta k 1 minus theta k Lk. So you see now what the quadratic matching technology is doing, that lockdowns are doubly effective because they're taking people out both of the susceptible pool and the infected pool. And then in addition, you have this eta k here because some of the infections are going to be taken out even if it's not for lockdown. Okay. All right. So then, as I said, 2 objectives: lives lost, that's the number of deaths, and economic losses. So economic losses explicitly is given by this mathematical expression. Let me give you what this mathematical expression stands for. If you look at the first term, what it has is that it has LJT times SJT. So those are the susceptible people who could have worked and are not working. What are they losing? They're losing WJ times 1 minus psi j. Why 1 minus psi j? Because WJ is what you could have produced if you went to work, but if you stay home, you may still do what we're doing here. We can do a less effective form of an in-person seminar. So psi j is going to vary across group, across sectors, etc. That can be incorporated for now. I'm just not going to look at the sectoral version, but that's where the economic loss is coming from. The second term is similar. It has the loss because of the infected people. So you want to reduce infections also because the infected people are not being productive. The third term is because some of the recovered are also not going to work because they cannot be identified. And then the final term is that if somebody dies, all of their future contribution to productivity goes. So the economic term, economic losses here already has some of the deaths in it because of this link between losing your future productivity. Okay, and then this was what I was showing you at the beginning. These frontiers, you can think of them as economic losses, minimizing economic losses plus some parameter times life lost, and that parameter more or less corresponds to what some economists call statistical value of life, but we do not take a position on the statistical value of life because it's a complex ethical issue as well as one where people disagree with. So that's why we're going to look at the frontier in its entirety for most of the talk. All right. Well, we do some mathematical analysis on this optimal control problem, but let me not present that because I want to jump to the results and show you a flavor of the results and then open it up for discussion. But before I do that, let me just make two comments. One is that targeted policies is going to have two benefits. And I think it's important to recognize both of them. One is that you can lock down the more vulnerable groups because infections are more costly for them. That's the pretty direct effect. But then there's a more subtle benefit, which is that once you lock down the older group, you can adopt different policies for the younger group, and you can go for different types of immunity, herd immunity based on a reduction in the susceptible population or vaccine immunity. And one way of seeing that is to look at this picture here, which is like the phase diagram for a two-group case. The three-group would be three-dimensional, so I'm not going to show you that. So essentially, we start at somewhere near 1,1, and we're always traveling downwards. Why? Because the susceptible population is declining all the time with people getting infected. Now, how do we travel downwards? If you did nothing and the infection rates are the same across groups, which there's some controversy on this, but most of the evidence suggests that heterogeneity is not on the infection rate, but what happens after infection, then you would be following the 45-degree line, the dotted line. But policy means that you follow different trajectories, curved trajectories, different angled trajectories. And then where do these trajectories take you? Well, the speed at which you travel is endogenous to policy. And the difference between the qualitative nature of the policies is that if by the time the vaccine comes, you're still in the white area, that's a waiting for the vaccine policy, which means that you do not reach herd immunity by the time the vaccine comes. On the other hand, if you enter that green area, that's loosely speaking the basin of attraction of infections going down from there on. So essentially, you're reaching herd immunity that even if the vaccine doesn't come, infections are going to fairly quickly disappear. But where you enter into that green area matters a lot. So the herd immunity that goes along the 45-degree line is very costly, but reaching herd immunity from other trajectories may not be as costly, as I'm going to show you. All right, let me pause here before I go into the quantitative analysis.
We don't have any questions on the chat right now, so okay. I suggest you carry on. I have a lot of questions for you, Daron, but I suggest you carry on, and we come to that. I'll carry on in that case.
Perfect. So most of the parameters we use are standard. I show you the data on the mortality rate. Again, we could go more detailed there. Of course, there's a trade-off here. We're going to compute optimal controls, which is not the easiest thing to compute. So if you have 80 groups, computing the optimal control becomes hard. The contagion rate, the number that you match for that is R0, which is the initial rate at which new infections come relative to recovery. So we target a rate of 2.4, which is, more or less the second wave of evidence from China. I'm going to start with a uniform interaction structure, rho equals to 1, just to show you what the differential lockdowns are doing. But then I'm going to show you this rho parameter calibrated to the BBC pandemic project, which is the best data available in our opinion. The group sizes are from the US, and the wages are essentially the same between young and the middle-aged, the two groups. But the old have lower wages because they participate less. So in the US, they earn about 25% of what the young and the middle-aged earn. The hospital capacity, as I said, we calibrate that to the Italy data. So you can increase mortality by about 10% when you exceed the ICU capacity. Low testing and
could I ask a question?
Sure, of course.
We have a question about that, and that is, how does the model handle the economic losses from hospital capacity? In other words, if a doctor is assigned to the intensive care unit, that doctor can't perform other productive healthcare activities. And we know that so many procedures were canceled and only COVID patients were treated.
Yes. So as I said, there are many other social costs like the ones that you've mentioned. So we're not incorporating them. All of those can be incorporated. And again, the models like Ferguson's, which had 40 authors, are much more detailed because they're written by the lab model. And so those are, they don't incorporate this, but those are more natural models for them to be incorporated. We view ours as a mid-scale model, or actually a small model, but some of those can be incorporated here as well. But our point, as I said at the beginning, is more like a conceptual one, is to show you how this robust differential structure emerges. So I'm gonna try to emphasize that, but those are all great questions. So load testing.
Another clarification question from the audience. Is the Pareto frontier a 2D surface?
Yes, it's a curve, yes. But it bends over, so I should have explained that actually, since I was a little bit rushing. The reason why it bends backwards is because if you have a lot of deaths, that's bad for deaths, but it also has economic costs, as I've explained, because people's foregone earnings in the future.
But let's see. So the question is a little bit more detailed. So since the output is economic cost plus alpha times cost of lives lost, and since you don't take a stance on alpha, then would that Pareto front be two-dimensional, or is it a curve?
Yeah, it's a curve in a 2D space, because I've reduced everything to 2 variables, and different. It's called chi in the model. Different chi's correspond to different points along the curve. So let me just quickly finish these parameters. So as I said, load testing and isolation. So most of the infected are lurking around if it wasn't for lockdown policy. So eta-j 0.9. And then so a key parameter here, which we don't really know what it is. There is no explicit data on this. But on the basis of introspection, etc., we choose this as 0.75. So which means that for every 4 people that you lock down, 1 of them is completely disobeying your lockdown. And then 30% of the workers are essential. So let me now show you the calibrated optimal policy. So now what I'm doing here is I'm showing the empirical equivalence that we compute with the optimal control algorithm that I skipped, but it's fairly standard optimal control that we solve numerically. The equivalence of the Pareto frontier. The red one is the uniform policy, and the green and the blue ones are the targeted policy. But here we are looking at 2 types of targeted policy. Since we have 3 groups, the fully targeted policy would target people in different groups differently. But we also look at a semi-targeted policy that doesn't distinguish the young and the old, sorry, the young and the middle-aged, it just distinguishes the old. And as you can see, the green and the blue are on top of each other. So all of the gains can be obtained by the very simple policy that treats the over 65s differently. And I'll come back to that in a second. But to show you what these curves mean, let me now pick a point or a couple of points and illustrate what the lockdown pattern looks like and what it implies in terms of economic and public health consequences. So let me take the red dot on the red frontier there. So you can call that a safety-focused strategy that says we're never going to tolerate anything more than 0.2% mortality among the adult population. That's pretty bad, but still one of the possible points you can pick. Or you can be like some Republicans and say we're not going to tolerate more than some amount of economic loss. So say, for example, you can say you do have an economic focused approach. We say no more than 10% decline in output. So essentially, that's 1 year's GDP equivalent of 10%. So what I'm showing you now are these 2 policies, or optimal policies corresponding to these 2 possibilities. The top one is the safety focused, and the bottom one is the economy focused. A couple of important points. First, you see that the lockdown is fairly extensive. So even close to 14 months, you have about 40% of the economy under lockdown. That's the only way that you can limit COVID-19 that has a very high infectiousness. That's the only way without extensive testing that you reduce spread of infections. And its economic cost would be over 37%, which means you're losing more than a third of 1 year's GDP. And despite that, you're putting up with 0.2% mortality. If you went for the economy-focused one, that's the bottom figure, you'll have a much shorter lockdown. The lockdown completely ends in about 7 months. But as a result, you have to put up with over 1% fatality. So these are grim choices. Before I show you how they are improved with the targeted policy, let me show you the reproduction rate of the disease. What you see with the reproduction rate is actually a telltale sign of what's going on. The safety-focused one waits for the vaccine, whereas the economy-focused one goes for herd immunity. How can you see that? Well, you could have seen that from the infection rate as well. Just before the vaccine comes, and that's why it's very clear to have a deterministic arrival of the vaccine. Just before the vaccine comes, you start letting people out of the lockdown. You see that from the lockdown policy. Why? Because once you know that the vaccine is going to come, you're okay letting the infections build up a little bit because the indirect effects of these infections on the very large susceptible population is not there. But because you don't have herd immunity, you have this uptick in infections, or the reproduction rate starts increasing. So if the vaccine didn't come, you would have a huge second wave here. But at the bottom here, you don't have that uptick because you've already reached herd immunity. Why? Because you've had the infections peak here quite high, and that spread the disease enough that you've achieved herd immunity, and that's why you had to put up with this relatively high fatality rate. All right, now bottom line, big improvements if you look at semi-targeted policy. So the optimal semi-targeted policy, if it's safety focused, locks down the old for until the arrival of the vaccine and reduces the 37% losses to less than 25. Same for the same mortality. Or the economy focused one reduces the mortality from over 1% to less than 0.5%. And the economy-focused one wants to use the older group's labor force as well. So once you have reached herd immunity, you can actually let the old come out as well. The herd immunity is not perfect. That's why it takes a while, but after that, you can let them come out. So this is going back to my earlier figure. You're going into the herd immunity region in a very asymmetric way. That's why you're saving a lot of lives, but still letting the economy open up. If you do fully targeted, now you would treat the middle-aged and the young differently, but the gains are very small because the big gains come from protecting the old. So why is it that treating the young and the middle-aged doesn't matter that much? Well, that's actually quite critical for understanding why you're locking down the young and the middle-aged here and why the gains are small. The reason why you're locking down the young here or here is because even though the old are under lockdown, if you didn't lock down the young, because of the slippage due to theta being less than 1, the old would still take the infection from the young. And that's very costly because the old are very vulnerable. So that's why you lock down the young. And now you can see why it doesn't really make a huge difference from a quantitative point of view, whether you lock down the middle-aged or the young, because you're not locking them down to protect themselves. You're locking them down to protect the old. So it doesn't matter whether it's the old or the middle-aged, and that's why semi-targeted policy does very well. All right, you can choose other points on the frontier, but quantitatively and qualitatively, the features are the same. You either wait for the vaccine or you reach this asymmetric herd immunity, and in both cases, you have huge gains from being the targeted policy. Now, you may say, you're locking down the old because the old don't contribute economically that much, so here we allow the old to be heterogeneous themselves, old retired versus old working, and it doesn't really matter. You want to protect both the old retired and the old working. The main asymmetry here is in the epidemiological aspect, the greater vulnerability of the older ages. So that's what this figure shows. Let me conclude because I want to open up for discussion. we do a bunch of robustness checks. I'm not going to go into them, but I want to make just a couple of additional points. One is that if you have testing and other social distancing measures, for example, protect the nursing homes by creating group distancing, the gains are huge. You can reduce mortality by an order of magnitude or economic losses by an order of magnitude. So there's some important policy issues that we have to talk about. Second, I want to contrast with Ferguson et al. So there are many differences from Ferguson et al. One difference that they emphasize is that they have a hard ICU constraint. So they say we cannot have infections exceed a certain level, and that's the reason why we're getting this on and off policies of lockdown, free up, and then another lockdown. Well, it turns out that's not actually correct. The reason why they're getting those second waves in Ferguson is because they're looking at suboptimal policies. So they're looking at lockdown and then no lockdown, but they're not looking at smooth policies that gradually reduce the lockdown. So even with tight ICU constraints, you may get a little bit of non-monotonicity, but you never get a second wave like they do. And that's what this figure here is showing. And then finally, the thing that's rather important is, of course, the network structure. So here we use data from the best data on this, which is much better than what's available in the US, which is old and not systematically collected, polymod, so the BBC Pandemic Project. So when you do that, the most important aspect is that each group interacts more within itself. That's the pattern that the off diagonal here are lighter, which corresponds to more intense activity. When that's the case, the qualitative features remain the same, the quantitative gains remain the same, but there are some interesting aspects that you get. And the most interesting one, and I'll conclude with that, which is that now you have another interesting non-monotonicity, which really reveals the logic of these models. So as you can see here, now you release the oldest group from lockdown and then lock them up again later on. Why is that? The reason is because when the old interact within themselves, once the infection rates among the old are low, even when the infection rate among the young is greater, you let them down, you let them out because they're not interacting with the young that much, so that slippage that from the young they're getting the infection is not a big deal. So you let them out, but once you let them out, they're always going to get some more infections because the infection has not been defeated. But the quadratic says that infections are building up, and at some point they become very costly, and then you lock it down again. So the non-monotonicity of this sort is quite endemic in these models, but critically will not lead to second waves as in Ferguson again, because you can manage it with optimal control policy. All right. Well, since I've said a lot about optimal control policies and really how parameters matter, and here is the final thing I'm going to show you. If you go to this website, and I can send you an email this address to those who are interested, you'll get a GUI where you can vary the parameters of the model and see how the optimal controls and the quantitative gains respond to different policies. So this is in the spirit of allowing other people to use these sorts of models, and of course they can be extended in multiple dimensions, as I mentioned. I'll stop now, and I look forward to your comments and questions. Thank you.
Thank you, Daron. This is really, really powerful. So we have a number of questions on the chat. If you have additional questions, please send them to me or to Laurelyn on the chat. And I will start with Fredo's question. How predictive do we believe such a simulation can be? My sense is that Ferguson was correct about the non-intervention scenario, but quite wrong about the effectiveness of the interventions. Did they try to fit their intervention model to what has happened so far?
Great question. And as I said at the beginning, there's a huge amount of uncertainty. And one thing I did not show is that if you look at the early works like Ferguson, the Washington-based, I forget now the name of the institute's model, there's another one in Europe, and you look at their predictions are way off. So every prediction that was made about COVID-19 is way off. Why is that? Well, there are a couple of reasons for why they're off. First of all, they used the wrong parameters. So I think there was a lot of uncertainty about the parameter. But even more importantly, and that's why we need to look into these, models from economics, sociology, quantitative sciences, is because social behavior is adapting. So even if you tell people, and there are some nice graphs, but I didn't bring them, not our work, other people's work. If you look at, for example, from data from Open Table, you see that in the US, people stopped going to restaurants before governors locked down the states. When the governors locked down their state, there's a further jump because not everybody was either cared about their own lives, but the other things, of course, here you're actually infecting other people. So there's an element of how social regarding you are, because there's a negative externality when you go and infect other people, and the quadratic matching technology is very important for understanding that. But in any case, so you see that people themselves were adjusting their behavior, and for instance, with masks and so on and so forth, that's really getting down the R0 of the disease down. So they didn't take that into account, but they also did not use all of the correct parameters for various different aspects. And I guess Ferguson et al., we have a huge team, they're updating their models. Some other people may or may not be updating their models. So I would not take any of the very specific quantitative numbers seriously. But what I've tried to emphasize are the general properties that are very robust across different formulations.
So thank you for that. Let me go to the next question from Munzer. How can one deal with vulnerable communities that are both poor and unhealthy, or do not have proportionate health support? Both lockdown and opening up result in more deaths.
Right. So, there are a couple of huge simplifications here. One of them is that I have completely abstracted from distributional aspects. So the assumption here is, of course, a completely counterfactual one, especially in the US, which does not have a good social welfare state, is you have the GDP and then you redistribute the GDP. Actually, given how bad the US social welfare state is, US economic policies have been actually the only sort of decent part of the US policy response to COVID-19. Unemployment insurance has been extended. Various different other policies have made sure that the most economically vulnerable have been protected. But there are other issues here that you want to go much more into the detail. But another important dimension of heterogeneity here is different areas. The ICU capacity is very different. And as you can see, the policy is quite sensitive to the ICU capacity. So if you do that, the same policy should not be used in Massachusetts as in Alabama, for example. But obviously, that's where the political economy of it comes. It's the practice is very different. Many states that don't have the ICU capacity have the very vulnerable population, not just because of economic poverty, but also with comorbidities, have adopted the most insane policies, exposing their populations to the infections. Actually, if you step back, in many ways, U.S. policy has been de facto the opposite of what we are advocating, because early policies, way towards the end of April, via nursing homes, the oldest population was highly exposed to the disease, because anybody could go into nursing homes. They had very low-wage employees, which were working in McDonald's and then going and working in without any check in nursing homes. And even infected people were brought into nursing homes so that their beds wouldn't remain idle, which was sort of an insane policy in the midst of a raging pandemic. But in any case, so there was a lot of incoherent policymaking early on.
So let me go to the next question. I have seen the argument in the context of simple SIR models that strict lockdown may be most valuable as we approach the minimum threshold for herd immunity, because it prevents overshoot past that threshold. I didn't see this come out in any of the optimal policy examples you used as illustrations. Why?
Actually, that's a great point. I did not get into that. So So going back to the figure that I showed you with the green triangle, so that when you enter that area, you actually travel in that area, and that's the overshoot. So the question is, you know, how costly is that overshooting, and how do you control it? And so the reason why you don't need special attention to that is because if you look at the optimal policy, it induces a peak way before you reach the herd immunity area. So by the time you get to the herd immunity region, the pandemic is already decelerating. So that's why you don't get into it with a very high overshooting momentum. But if instead you did completely uncontrolled, so that the quadratic, took you almost exponentially up, then you would get into the herd immunity area and you would travel way into it. But optimal policy never does that. So that's a great question. Thank you.
That's wonderful. All right, here's another question from the audience.
Roger had a question, but yeah, okay, yes.
That was Roger's question.
Okay, all right.
That was Roger's question. Thank you, Roger, for that good question. Some of the optimal policies decrease the lockdowns and then increase it again. Presumably, there are some large inertial effects, for instance, lags between reducing lockdown and any economic increase. Would modeling this substantially affect the results?
Great question. Great question. That's a fantastic question. So, I have trumpeted the benefits of looking at optimal control relative to the sort of ad hoc policies a la Ferguson et al., for example, but I should have also been upfront about the shortcomings. Well, you're dealing with complex social problems here, and you cannot tell people, okay, you're going to go down a little bit and then you're going to go back. So there are going to be delays. There are going to be, perhaps when you use more complex policies, there will be more disobedience to the policies. I think all of those are great questions, and one should really think about them. We don't have a good lever for thinking about how you can make these inertia things change, or even have a way of quantifying it. But what I would say is that if you approach this problem as an optimal control, you can add additional constraints. So for example, one constraint could be that instead of LJT as I've formulated it, LJT itself has to be a step function. So it can jump down, but it cannot go down. So it can jump down and it has to still remain step for a while. So those might be easier to implement, easier to explain. So there are various ways in which you can add additional constraints, and at least our numerical algorithm would work quite well here. But again, if you want to increase the number of state variables, then you might run into other numerical problems.
All right, another question from the audience. Can you comment on policies for different geographic regions and possibly urban versus rural?
Great question also. So the rho, which is the social interaction component, is most likely very, very different in urban versus rural areas. So the evidence so far from cross-country and cross-county is that rural areas are generally doing well, better, sorry, not well is not the right word, doing better, because even without lockdowns, there aren't as many interactions. Like, if you don't have a public transport system like New York or Massachusetts or London, even if you don't do any lockdowns, you're not going to get as many infections. So those would immediately translate into very different lockdown policies, in addition to, as I've pointed out, ICU capacity. There is also a debate as to whether the beta parameter, which is the infection rate conditional on contact, is a function of geography, like, for example, heat, the way that droplets travel, and what, what the way that the virus is transmitted may depend on other external circumstances, but it's very, very poorly understood at the moment, I would say.
Daron, we're getting close to the top of the hour, so let me ask you a couple of broader questions.
Please.
What do you think MIT should do? What is this policy? How should we interpret the results from this policy in the MIT context?
Well, I mean, I think MIT is a very different community So there are many more things that we can do as a community that, Massachusetts or New York cannot do. First of all, our students live together, live in confined places, but they have less interaction with the broader outside community. We're also a very well-educated group, we have great healthcare resources. I would trust that MIT students are socially responsible, so they would behave in ways that perhaps the average American would be harder to convince them to behave in ways that are more self-regarding. And we can reorganize dorms. For example, ASU and others are working on the possibility of organizing students in ways that you can minimize infections and do better testing. I think all of those are things that we have to consider. Well, the question that comes down to the following, okay, we can all be extremely risk averse and say, not on our turf. And some governors may say that. But of course, the cost of that is exactly like, you've hinted at, Munzer and others have hinted at, the economic costs are very high and they also are very unequally distributed. So, and if we have to open up to some degree, well, if MIT cannot manage the opening up, then how can, high schools or elementary schools can? So I think we are in a much, much better position in terms of having a very well-educated, very conscientious population, very predictable behavior in many ways, and also we have great healthcare resources. So I think there are a lot of things that we can do, and again, this is something that intellectual resources from many disciplines can help us navigate much better.
What is your most positive, optimistic outlook for the rest of the year?
I don't know. That's really hard. I mean, I think I am really worried that the policy failures in the U.S. are going to continue, and if they do, I fear that infections being down where they are in places like Massachusetts or California may not last, and certainly there are very different behaviors across different states. So there are a lot of concerns that would keep me up at night if I weren't so tired during the day.
Daron, thank you for being with us and for sharing this amazing work with us. I'm sure that many of the students in the audience are inspired and will love to continue to support and expand the work.
But I would love to get additional questions from anybody who's interested. Thank you for hosting me.